Now, thank you very much. We go to the next instruction course, that is surgical management of pediatric cataract, video-based learning. I am Dr. Jagat Ram, and with me faculty is Dr. Jaspreet Sukija, who is Professor, Department of Pediatric Ophthalmology and Strabismus at PGIMER Chandigarh. Dr. Parul Chawla Gupta, Associate Professor, main interest in pediatric and does all cataract, cornea and refractive surgery. And Dr. Love, who is founder and executive director of Netralayam, Kolkata. He was senior consultant, pediatric ophthalmology, cataract and refractive surgery and ocular trauma, and formerly he was assistant medical director at Shankara Netralaya, Kolkata. With this brief introduction, we have 4 speaker, 4 topic, and I will be inviting Dr. Parul Chawla Gupta to speak on basic steps of pediatric cataract surgery.
Thank you, sir. Good afternoon to everyone. Today I'll be presenting the surgical management of pediatric cataract, a video-based learning course, along with my co-instructors and chief instructor, Professor Jagat Ram. So the basic steps of pediatric cataract surgery for a novice pediatric surgeon. Congenital cataract has a worldwide prevalence of 4.24 per 10,000 people, with the largest prevalence in Asia. It is one of the most important treatable causes of childhood blindness. So for unilateral, we usually operate between 4 to 6 weeks of age, and for bilateral, 6 to 8 weeks of age. However, there are increased rates of post-operative glaucoma in the first 4 weeks of life. So starting with the surgical part, the superior clear corneal triplanar incision of 2.2 or 2.8 mm is preferred in children, as the wound is protected by the upper eyelid from trauma. Scleral incisions also can be given, and smaller, tighter fitting incisions help in better maintenance and stability of the anterior chamber. We should minimize the times in and out of the eye, and for the side ports, 2 uniplanar incisions are used. We should address small pupils in children. Small pupil is less than 4 mm. It leads to higher complications, as we all know. There can be small pupil due to posterior synechiae, as in uveitis, trauma, persistent fetal vasculature, or in cases of pupillary fibrosis. We should dilate the patient pre-op with tropicamide or cyclopentolate, or we can use intraoperatively 1 in 1 lakh adrenaline. We can also now use intracameral mydriatics like phenocaine, no financial disclosures, which is a combination of tropicamide, lignocaine, and phenylephrine hydrochloride. Why anterior capsular rhexis is difficult in children? Because it is thinner, elastic, it is convex shaped, it tears easily and runs in the periphery. AC is shallow in these eyes, IOP is lower, there is a poor red reflex due to opacities. Anterior capsular rhexis can be done by various means, like using a curvilinear capsulotomy, using a needle, using the vitrector, using the tip technique, that is a 2-incision push-pull technique, or using the femtosecond laser, plasma blade, or precision pulse capsulotomy, or the Zepto. And we should always stain with the trypan blue dye, that is 0.06%, which decreases the elasticity of the anterior capsule. The anterior CCC should be around 5 mm, and the posterior CCC should be around 4 mm. Tips are, we should pull the capsular rhexis centrally. We should use a cohesive viscoelastic, and we should take frequent bites of the anterior capsule. So cohesive viscoelastic, it flattens the anterior capsule, keeps the anterior capsule taut, and counters the effects of low scleral rigidity and vitreous upthrust. Then multi-quadrant hydrodissection should be done using a cannula mounted on a 2 cc disposable syringe, and at least 3 quadrants should be done. Coaxial or bimanual lens matter aspiration can be done. Start from the periphery and swipe clean. For the IOL implantation, the anterior chamber is filled with high viscosity viscoelastic, and push the leading haptic underneath the anterior capsule, then push the trailing haptic into the bag using a Sinskey hook. A single piece hydrophobic acrylic IOL is preferred for in the bag placement. There is less PCO in such IOLs, as well as less pigmentary deposits. 3-piece can also be used in case of an inadvertent PCR. Monofocal IOLs are preferred in children. Multifocal can be used in children more than 5 years of age with bilateral cataracts. The lens IOL material, if it it is a silicone lens material, then it can lead to calcification with asteroid, a hydrophilic and opacify early. So the hydrophobic acrylic is the most favorable. The PMMA is very good if there is a big PCR and it is stable in the sulcus. But for that we need to increase the incision. Peripheral iridectomies should be done in patients with aphakia who are left aphakic or uveitic cataracts, as they prevent the formation of iris bombay or any traumatic cataracts. It can be done with a vitrector, and if there is a bleeding, we should give air tamponade or viscoelastic tamponade. Then primary posterior capsulotomy and anterior vitrectomy can be done, as PCO is the most frequent complication. So we do it in the cut IA mode of the cutter, and if we don't do it, then it leads to 100% PCO rate in children. So this is done in children under 8 years of age, but vitrectomy, capsulotomy and vitrectomy is done up till 6 years, and we do just PCC till 8 years of age, or in children who are mentally retarded or cannot cooperate for a NDA capsulotomy later on. So suturing must be done. It can be done with a 10-0 nylon suture or a vicryl suture. Vicryl is absorbable. So why suturing is done in children less than 2 years preferably? Because they have a low scleral rigidity, increased elasticity and more vitreous upthrust. This leads to AC shallowing and increases chances of end off later on if we don't suture the wounds. Also, we should give preservative-free moxifloxacin intracamerally and subconjunctival dexamethasone. We can also give intracameral dexamethasone or Canacort. Post-operatively, topical corticosteroids should be given 6 to 8 times a day, tapered in 4 to 6 weeks, and topical antibiotics 4 times a day. Topical cycloplegics like cyclogel or homide for 2 weeks, preferably homide. And follow-up period, we should use glasses or contact lens and patching for amblyopia. So these are some videos which I'll show. Music. So after making the side ports, we stain the anterior capsule with 0.06% trypan blue dye and wash it off. We fill with the viscoelastic, that is a cohesive viscoelastic is preferred. We use the cystitome to start the incision, and then we complete it with the Utrata forceps. We do a multi-quadrant hydrodissection, at least 3 quadrants should be done, and then we do bimanual irrigation aspiration. We should always polish the bag and the capsule because PCO rates are very high in children. Then we enlarge the incision and put the IOL. So this patient didn't have a PCN, but we still put a 3-piece IOL because the patient was not reporting. And after putting the IOL, we do a vitrectomy and a posterior capsulotomy and fill the chamber with air after suturing. This is the use of intracameral mydriatics in pediatric cataract surgery. After staining and washing of the trypan blue dye, we put phenocane. You can see how beautifully it dilates. Have to re-grasp the anterior capsule again and again, and you'll see how beautifully the nucleus parted comes up. This is another video in which we used triamcinolone intracamerally to prevent post-operative inflammation. This was a single piece which was implanted. Then we did capsulotomy and anterior vitrectomy, and then after hydrating, we put a wee bit of triamcinolone on and washed it off, and then put the air bubble. This was another video in which there was a calcified anterior capsule, so we used the vitreous cutter to cut the anterior capsule. So we were unable to use the cystotome for making an opening, so we used the retractor in the cut IA mode. This was an almost absorbed cataract with calcification. We did a PI in this because the patient had microcornea. So any eye is less than 10 millimeter white to white, and less than 17 mm axial length, we leave a phakic. So that's why we did a PI. So summary, congenital cataract is an important treatable cause of childhood blindness, and it should be managed promptly to achieve good visual acuity. In the bag placement, along with primary posterior capsulotomy and anterior vitrectomy, is essential in the younger age group, and post-operative care and follow-up are inevitable to achieve an optimal outcome. Thank you so much.
Thank you, Dr. Parul. Thank you, Dr. Parul, for your excellent presentation. You have shown very nice videos. You told in one of the slides that you use mediatic intracameral. Which mediatic you use?
So we can use intracameral epitrate, or that is ADR, adrenaline, but ideally it should be preservative free, or we can use phenocane. So they have a combination of tropicamide, phenylephrine hydrochloride, and lidocaine hydrochloride. So that beautifully it maintains the dilatation of the pupil and causes the dilatation of the pupil is very small, and it maintains it also and provides anesthesia also.
Madam, do you dilute it?
No, we don't dilute. We just put just 4 units, 0.05 millimeter, 1 cc.
You use syringe or you use more final syringe like
30 kg, yeah, insulin one, yeah.
Another thing is that in the post-operative period, surely I think beside frequent topical steroid, we use cycloplegic agent.
Yes, sir.
And we have seen several parents, they may not use cycloplegic agent.
Yes.
And people will be 360 degree, Syniki will be there, 360 degree. So I think we have to take care of that point.
Yes.
Usually we consider that, okay, there is no inflammation.
Yes.
But I think that once I think inflammation is there, that adherence and annular Syniki will be there.
Will be there. Yes,
People
sir.
will be totally close. In several cases, we have to do synechotomy and again resurgery.
Membranectomy. Yes, sir. Yes, sir.
Any question from the audience?
In such case, can we advise atropine drops on table? Or
Atropine drops are usually avoided in children actually because they lead to hypothermia.
Usually we do whatever dilatation we achieve it before starting the surgery. That is our first aim, and we have not used during surgery or at the end of the surgery we have not used atropine.
my intention was to prevent synechiasis.
No, you are right, but
If there is a synechiasis, atropine vision will be clear.
Yes.
So I think hometropine is a better option if you want to put at the end of the surgery. But usually you have a dilated pupil with a cycloplegic which you've used pre-operatively, plus you use intracameral mydriatrics as well. So on the first post-op day, usually the pupil is dilated unless you use pilocarpine for doing a PI or something. So probably it works well, and then you start steroids and you start hometropine the first day only. So the first post-op day you start hometropine as well.
I think pilocarpine should be avoided in these children, particularly in children. But homide is fine, that is all right. Because that will dilate only mid-dilate, that will a bit mobilize the people.
And every case you go for PBI.
Primary
PI.
posterior capsulotomy. PIs.
No.
There are certain cases, like if we are leaving the patient a phakic, so in order to prevent pupil block glaucoma, we do that. Or in case the patient is has history of uveitis, then the posterior sanicae will form on the IOL. So to prevent that, to prevent the aqueous from not coming, so we make a PI.
Every time we have to subject them for minor thing, but under the anesthesia.
Yes.
We can do prophylactic PI.
It is not recommended
Not
in all
required in
children.
Not in
cases.
pseudophakics. Not in pseudophakics.
I
The phakic,
think
yes, you
in
have to
certain situation, if it is a case of JIA, case of uveitis, and we know people is small, selectively we do peripheral iodectomy, but not once we place IOL, dilatation is good, place IOL in the bag, then we don't do usually PI. So we will have more discussion at the end also. Now I invite Dr. Love, who will be dealing also with the extremely important subject on which success depends. That is the IOL power calculation, because IOL power calculation is very tricky. Not after 6 to 8 years it is much better, but particularly from up to 6 years or even 8 year, how much under correction, what should be done, I think he will clarify it.
Thank you,
Dr.
sir,
Love.
and thank you for giving me this opportunity. So this is another important aspect and very complicated aspect, because we don't have a very clear answer to most of the pediatric biometry issues. And why is it challenging? Because again, if it is a pre-verbal child, maybe a very poor cooperation for the biometry, poor fixation if nystagmus is present, and it is generally many cases it is present. Myopic shift related to eye growth post-operative, and those factors have to be taken under consideration. Fixed IOL power or change in IOL position of the growing eye, and post-op amblyopia management. Those factors have to be considered when we are considering what power of IOL has to be implanted. Requirements, I think anyone having a full-fledged pediatric cataract unit will have to have the handheld keratometer along with a normal ultrasound A scan, because if the child is not cooperating and if we are doing biometry under general anesthesia, then we need a normal contact A scan or a immersion A scan. And this is a very small video which shows how we do it in the OT, and this is a case in which, if you notice, we have not put any speculum in the eye, because if you apply even a wire speculum, that may lead to error in biometry. And the cornea is kept well hydrated after the initial keratometry, the axial, and one thought process is that contact method should not be done before any cataract intraocular procedure. But in that case, we will be subjecting the child to a general anesthesia twice. So this is a compromise in between. Once the biometry is done, then the eyes is cleaned and properly draped. To minimize errors, yes, we should not use any speculum. To avoid problems related to corneal dryness, measurement should be taken as soon as possible after induction of anesthesia, and BSS should be instilled frequently to maintain a smooth corneal surface. Now the complicated part, what IOL formula to use, and this I think in between also we can have discussion. Like in pediatric eye, they have a shorter axial length, steeper cornea, and smaller AC depth. So axial length, error in axial length measurement will affect IOL power more when compared to adult eye, and as you can see here that with per millimeter the variation can be as much as 3.75 diopters when compared to an adult eye of 2.5 diopter per millimeter. No formula has proven advantage, but it's again we'll discuss that in the coming slides. And as you can see, the axial length varies quite fast, and in the first 2 years, even the keratometry value keeps on changing. So the IOL formula. And for the undercorrection, these are very important facts which we should know. Very crude method some people use is that with axial length measurement the IOL power is decided, and in present day it should be best avoided. It is better to have a proper keratometry reading along with axial length for biometry. Undercorrection, one thought process is that in less than 1 year, if you are operating, it should be almost 60 to 70% undercorrection. 1 to 2 years, 40 to 60, 2 to 3. Again, this is a thing in which there are a lot of varying opinions, and one thought process is that very high hyperopia may actually induce amblyopia if the child is not cooperating with spectacles after the surgery. So it is always better to give a smaller hyperopia and manage the myopic shift later on, because once dense amblyopia develops, it is of no use. Formula, I think most commonly what I use, I would say, is SRKT in smaller eyes Hoffer Q, and we can use also the newer Barrett formula. And this is another important factor, target refraction. If we aim for small hyperopia, then to balance the myopic shift, that is what we discussed just now. Points to consider is, if the child is very small, then definitely we have to aim for slightly more hyperopia, because then the myopic shift will be faster. And at a younger age, we may end. I just maybe 2-3 weeks back, I saw a child which I had operated maybe 6 years back, and we aimed for a small hyperopia. It was at the time of surgery, child was around 2 to 3 years of age, and now has a myopia of almost 8 to 9 diopters. So myopic shift is unpredictable, but one of the predictive factors in this is if it is a unilateral cataract, like the status of the fellow eye. If it is a unilateral cataract, then myopic shift will be much faster. So if in those cases, we can always aim for a slightly more hyperopia. Less hyperopia we have already discussed. Expected compliance is a very important factor. If the child is from a rural background, many times they come back and with a history that they are not using spectacles. So in those cases, is always better. And if it is a very young child also, we should err in favor of IOL implantation and a smaller hyperopia, because if the child is not using contact lens, the whole purpose of the surgery is lost. Parents' refractive error is another factor. Children of parents who have high myopia, then we expect a higher myopic shift. And limited range of IOL power. This is another important factor. Some children, if you do biometry, you will get IOL power of maybe 33, 34, 35 diopters. And the power which is generally freely available is up to 30 diopters. So that decision has to be taken. What do we do? I think sir will give some idea on that. And bilateral cataract, then it is easier decision making, but unilateral cataract, as I had already discussed, that myopic shift will be much faster. Both eyes, the duration of gap between both eyes, that is another factor that has to be considered. Varying opinions I have heard, but what I do is I generally operate them maybe 2 weeks apart. Again, just last slide, that about the choice of the IOL when we are doing in children, whether it is hydrophobic or a PMMA or a hydrophilic. Hydrophilic is a big no in children. We don't use hydrophilic lenses. Hydrophobic biconvex is a definitely universal choice, but now with more experience, we are using aspheric and blue blocker lenses also. And toric in older children when power, and especially if they have a higher cylinder, then it is always advisable to give toric lenses. EDOF lenses is newer kid in the block. We have started, but no definite data is available right now. Thank you so much. Thank you.
Thank you, Dr. Love, for your excellent presentation. I think this is extremely important. Any one or two questions for him? Otherwise, we will also have questions at the end also, but in between, I think 1 or 2 questions.
Barrett's. I do. I'm my I would say it is still 50-50 SRKT and Barrett's.
I think while we started pediatric cataract surgery, I used to initially use SRK2 long back, about 35-40 years back. Then we shifted to SRKT. Then we had study from M.E. Wilson et al. And we show that these four formulas, whether SRKT, SRK2 and Hofer and other, they have no significant difference in the outcome or in the refractive error. But after this SRK2 shifted to SRKT, then even Barrett at present. So we have to see which is the best.
Another important thing is that in children, whatever formula I had done one study in which the outcome was that almost 22% of these children didn't end up with the target refraction what we had taken, because of the change in the effective lens position due to the posterior capsular axis and anterior vitrectomy. That is another factor.
Yeah. One important thing which he said is that if you try to keep less under correction, means that whatever residual refractive error should be less, not say +7, +8, because it takes longer time for reduction. Because and if it is a bilateral cataract, unilateral cataract in the eye which you are going to operate, so difference should not be massive, because asymmetric there will be issue of rehabilitation.
Suppose if the other eye is slightly higher myopia, then what is the choice? Sorry, can you tell something? Suppose the better eye, an eye with non-cataract, which doesn't have cataract, has myopia of 4-5 diopters, 5 diopters. Then what is the choice of?
Yeah, I think then there are certain such situation where other eye is myopic, cataract is in one eye.
One eye.
So there you don't keep a much residual hypermetropia. You don't keep say plus.
Maybe we can give emetropia in those.
Close to emetropia, but still this will go toward the myopic side. We will discuss more.
The difference should not be more than 4. Because that will lead to an IC63.
Yeah, otherwise if it is a gross difference more than 5, 6, 7 like that, then acceptability and that imbalance exists.
Yes.
So now I invite Professor Jaspreet Sukija, who has done tremendous work. I think he is a purely pediatric ophthalmologist, and he has done a lot of work in the field of pediatric ophthalmology, pediatric cataract. He will be speaking on intraocular lens implantation in children, when to place and where to place. I think very important again.
First of all, thank you, sir, for making me part of this IC. Of course, he's my Guruji. I've learnt everything from him. So, a little modifications, what we are going through, most of which is what I've learned from him. So, I will be just discussing when you need to place the IOL and where should you place the IOL. So when to place the IOL is just an indication of IOL implantation. So we were just discussing if the axial length is more than 17 millimeters, probably yes. A corneal diameter of 10 millimeters or more could be an indication, but again you have to take the axial length into consideration. Less than 6 months, it's a big no. So the consensus has gradually changed from earlier it was 2 years, now it's come down to more than 6 months if your biometric parameters are within your range. Of course, there is no consensus as yet. Some people still avoid in infants. And yes, demographics in our country has a big role. We can't be just going what the Western literature says that, okay, fine, just put contact lens, infant aphakia treatment study. Here you have children who are from poor socioeconomic strata, they come from far off places, follow-up is an issue. So we can't be just leaving them aphakic and poor children when they grow up are severely amblyopic. So those things also matter when you're planning and deciding if you need to place an IOL or leave the child aphakic. So where to implant it? Of course, conventional what we've been taught is endocapsular implantation, that is in the bag. You could do the modifications which have come up are the optic capture, which could be an anterior optic capture or a posterior optic capture depending upon the indication. Sulcus is a big no in children, but yes, if you have sometimes you are stuck in a situation where there is no other option. Probably sulcus in an older child is maybe an option. And yes, the other things which are coming up are the bag and the lens, which has shown very promising results, but of course it's a patented lens. The cost factor is there. We don't have that in India. So just taking you through some of the the sites, or you can say the placement of the IOL where it can be done. If it's just a routine pediatric surgery, cataract surgery, and which has been very well documented by Dr. Parul here, you need to stain the anterior capsule. That's a must in children, because what happens is one is the elasticity decreases when you stain the capsule. The other thing is the delineation is much better, and so what you want is an appropriate size anterior capsular axis. So that is what we've done. And of course use a high cohesive viscoelastic, inflate the bag, and then your posterior axis could be either after the IOL or before the IOL. Here I am just trying to do it before the IOL, and if you are confident enough, yes, before the IOL is also a good option. So you have a round axis there where you can see, and then you put your triamcinolone on, do your anterior vitrectomy, which is an indication in children less than 6 years usually. So you do a good limited anterior vitrectomy, and then once you have got a good anterior capsular opening and a posterior capsular opening, what you do is then you place the IOL in the bag. So this is what is done. It's a foldable IOL what you are doing. It's a 3-piece hydrophobic acrylic IOL, and so you have to be a little bit careful so that the haptics just don't go down into the posterior capsular opening what you've created. So gradually you dial it inside the capsular bag, and the ideal situation would be when you have an anterior capsule which is covering about 0.5 millimeters of the IOL. So that will lead to much less chances of posterior capsule or visual axis opacification. That's the conventional way of implanting the IOL, and that's the bag where it should be implanted. So the other thing is, what you can do is, as was shown, you could do it after the capsular axis. So here we have a white cataract. The capsule, you can see, is quite friable. We've stained it. It's almost like the lens matter is coming out, hypermature cataract. So we already put an IOL. Now because it was a friable posterior capsule, I didn't want to mess up and decrease the chances of IOL in the bag. So what we did was put the IOL in the bag and then the posterior capsulotomy. So these are some of the indications where I would do the capsulotomy after implanting the IOL. It does become much easier once you've implanted the IOL and then you do a posterior capsulotomy. So this is just another one. What we do, a comparison what we did in implanting an IOL in the bag versus doing a posterior optic capture. So a posterior optic capture, I mean your optic is in the is behind the posterior capsule, the optic behind the posterior capsule, and your haptics are in the bag. So what happens is, the main purpose of doing it is there is nothing in the bag, just the thin haptic. So what happens, anterior and posterior capsule fuse. So what you are more interested here is that prevention of posterior capsule opacification. So this is one way of helping it, and of course you avoid an anterior vitrectomy here. So I'll just take you through this procedure. So this is a little older child, and we haven't put any dilators, and you can see we were just discussing the intracameral dilators. So once we just put these intracameral dilators here, you will just see how the pupil dilates. So just it's gradually it's going on. We haven't put any dilators, or maybe a few seconds it just dilates, and you can see the clear view of the cataract. And once you put the viscoelastic, the pupil just blows out and you have a very good view of the cataract. And then of course you can proceed accordingly, do the lens matter aspiration. We've done the anterior axis, and once we've removed the lens matter, what we do is you have a posterior axis. Now here the posterior axis has to be done before, should be a little larger. You can see the posterior margin is just almost like just the size of the anterior margin. So again, be careful with first put the IOL in the bag and then very carefully nudge it behind the posterior capsule. So you can see here one of the edges gone, and we are just putting the other edge here. And at the end of the surgery, if you see a dumbbell shaped posterior axis, this is a dumbbell shaped axis. This shows that your optic has been captured successfully. It's a locked IOL. So there will be no decentration here. The optic haptic junction has been locked by the posterior capsule. So that is what I wanted to say. That this is also a good technique if you want to prevent posterior capsular opacification. And in our study, we did find that the inflammation was less in patients who underwent a posterior optic capture. So that was posterior optic capture. These are just to show you some of the photographs what we had, the study what we did. This is in the bag, and this is a posterior optic capture. So what happens is you have a good sommering ring formation. Everything is sequestered in the bag. Nothing comes out. And over a, you can say a 1 year follow-up, you can see some lens epithelial cells proliferating with a good rexis. If you see the anterior rexis is fairly good, it's covering the optic. A posterior capsulotomy, a fairly good opening, but you still have the epithelial cell proliferating. And in the other eye, what we did was the capture. You can see everything is in the bag. These epithelial cells are in the bag. Nothing is coming to the center. So it does help. But obviously in our study we found that the incidence of PCO was same. I mean, did not find any visual axis of opacification. So it's whatever you're comfortable with, you can do. Then the other thing is this thing. So once you have children with ophthalmos as well, where you have a large eye, a large cornea, and maybe the bag is kind of, the zonules are little stretched, and the IOL might shake in the bag. So the decentration possibility is much higher. You can see here there's a corneal transplant that has been done, a keratoplasty in a child with the ophthalmos. He has multiple surgeries. So with multiple surgeries, synecdoche formation, it really becomes difficult, and you have to place the IOL in the bag, because anything different from that will lead to complications. So what happens here is, again, the normal routine steps are done. You stain the anterior capsule. Be careful. Try to do a corneal incision, because obviously you have a bleb there which will lead to failure of the trabeculectomy which has been done. And then what you do is a routine surgery. I'll just take you through here. Sorry. Yeah. So here we go. So the main thing is you put the IOL in the sulcus here, because we've done a posterior capsulotomy. You place the IOL in the sulcus and capture the optic with the anterior capsule. You don't want to go in the bag because of the condition of the eye, and there is a possibility of decentration and the IOL just going back. So what you do is, this is the post-op follow. What we did was, you see a dumbbell shaped and oblong anterior capsular axis, and you see this round thing, a posterior capsulotomy. So we have a clear visual axis after on the follow-up. So in children with ophthalmos, probably this might be a good condition. You do an anterior optic capture, but not in routine pediatric cataract surgery. So I'd like to conclude here by saying that primary IOL implantation is a good option when considering pediatric cataract surgery. Should be avoided less than 6 months, and in selected cases. Conventional placement of IOL in the bag has issues with VO, which people have shown up to 30 to 40% incidence of VO, and of course secondary glaucoma. Refinements in techniques such as posterior optic capture have been shown to be better in terms of inflammation. I would not say VO. In selected cases like ophthalmos, you could do an anterior optic capture which stabilizes the IOL. And yes, bag in the lens is a promising technique in literature, but it's limited by its availability. Thank you.
Thank you, Dr. Jaspreet, for excellent presentation and excellent video. Particularly the dilatation of the pupil is very impressive, and he does beautifully, I think, posterior capture. Usually we do place the IOL in the capsular bag. That is our primary. But recently we started doing even the posterior capture of the IOL. That is the optic behind the posterior capsule. So he does very beautifully. Any question for Dr. Jaspreet? In between, I think while my slides will be on, I think ask question.
They want to have questions.
Is it there's a three-piece IOL that you capture behind the PC?
Yeah, I mean, see, in literature you have single piece also. They have done single piece toric IOLs also in children with posterior optic capture. But then, because it has a broad optic-haptic junction, it really becomes difficult there. But you have single piece IOL with thin optic-haptic junction. You have those rigid IOLs, PMMA IOL with thin. You can do that. People have described doing that. So if you have a thin optic-haptic junction, yes, you can do the capture. It's not a must. Yeah, so as I said, I think up till about 6 years, what's described in literature as well. After 6 to 8 years, if the child is cooperative for a YAG or something, probably yes, you could avoid it. But again, try to do just a posterior capsulotomy, not an anterior vitrectomy. Up till 6, you have to do an anterior vitrectomy. But after 6 years, just do an anterior capsulotomy. And after 8 years, probably depending upon how cooperative the child is, or if the patient has a uveitis or something, then yes, you do all those things. But otherwise, you can leave it.
Yeah, you want to ask?
The technique is, first of all, you don't have to be careful about the size of the rexis, the anterior rexis, where they say that, oh, it has to be very certain, because if you have to put the IOL in the bag, you need the covering, you need the anterior capsule covering on the optic. But here you don't have to be careful. So even if you have a large rhexis, doesn't matter. But the important thing is posterior rhexis. If you have a small posterior rhexis, you're going to tear it. In young children, in infants, really doesn't matter. I've done so many cases with small rhexis. It's so elastic that it just goes. But in older children, in my experience, if you don't have an appropriate size rhexis, say about 4 to 4.5 millimeters, there is a high possibility of tear. So you have to have a good size rhexis at that moment. And of course, when you're doing it, starting it, probably a 3-piece IOL is the best thing. I still use the 3-piece IOL because I'm comfortable with it and it feels safer with that.
And if you're not very confident, after IOL implantation with a high-speed cutter also, nowadays it's very easy.
Yeah, I mean, again, the size of the rhexis is there. So the size of the rhexis has to be bigger as compared to what you conventionally would use for in the bag implantation.
Will you stain the posterior capsule before?
Not really. I mean, we did do a study, but it's not really required with such a good glow. After you remove the cataract, you have a good glow, and probably doing a rhexis without the dye is much better, because then sometimes what happens, it goes through the zonules behind, and then the view is obscured. So that helps it. Considering that if it becomes because the posterior capsule is definitely more elastic as compared to the anterior capsule. So, but that would help you when you're implanting the IOL rather than making it more brittle and leading to tears.
And one more thing for the technique that you asked, you can just puncture it with a cystitome, the posterior capsule, put some cohesive viscoelastic in the Burgess space to separate it from the anterior vitreous phase, and then pull it around.
Sir, can we consider iris glow lenses in case where bag is not there also?
So I would not really advise that, and probably there is no evidence in literature that you should be implanting iris claw lenses, because first of all you are sticking it to the iris, so repeated inflammation is going to be there. Secondly, there is a high rate of disinclination in these children. So after about 5 years, you're going to have disinclination. This is posterior iris claw, not anterior iris claw. Anterior iris claw, you are going to have endothelial problems coming up along with that. So if you have aphakia where you no sulcus support, probably yes, TSF IOL would be the other option in case contact lens is not the.
I'm a vitreoretinal surgeon, so I go posteriorly with a 25-gauge trocar cannula, and after I put the lens, I do a PCCC with a cutter and an anterior vitrectomy.
From the pars plana. So what happens in children, the pars plana is not really developed. That is the issue. So you don't know where you are going. The other thing is, yes, people have the advantages is that the traction is much less. So if you do from the anterior route, you are going to create a little traction on the vitreous. But with the pars plana, the advantage is you are not creating a traction. Yes, in Western countries, people are still doing. They usually follow that go through the pars plana. But obviously, what is good in your hands was best probably.
I think that can be done with the vitrectomy cutter. You can do primary posterior capsulotomy also. Usually we do with the utrata forceps with the initial nick with the needle cystitome. But if you fail, you are not that we 100% succeed. In that situation, you can use vitrectomy cutter. That is another safe way, because it will provide also equally good opening. So we will have any question, yeah?
Can you please repeat the question? Can you use the mic, please?
Do you consider to put a secondary IOL after 5 years, 7 years, if you have myopia?
Yes, myopia initially, you have left the child aphakic, or how's it? Or you put the IOL?
You put the IOL.
Myopic shift?
Sulcoflex.
Yeah.
Sulcoflex, something like that.
Yeah, I mean, if you got a myopic shift, then you need to exchange the IOL.
I think
Yeah,
there
because,
are two things.
Yeah,
He is
one is-
right. There are two things. One is, if it is a low myopia, you see whether you can implant a piggyback IOL, because first IOL is in the bag, second will be in the sulcus. That is one way. Or if there is a gross shift, IOL is certain time not available. Those children operated by me 35 years back, few of them, very few of them, they have a very high myopia, minus, not all, but very selectively, very. So there it is a IOL exchange which is required. So you have to see whether IOL exchange is required, or implantation or piggyback IOL is required in the sulcus. So we have to assess all that.
Depend on the case. Thank you very much.
Thank you so much. And now I will be going to the last presentation. Please on my presentation. I think audio visual people on kar do. That is surgical tips and tricks for complicated pediatric cataract. I think each procedure we do, whether any procedure you do, you pray to God. But we remember our Guru also. So I owe my gratitude to my mentor and teacher. They are my mentor and teacher. Before me, I became head of the department after Professor Amod Gupta. I also owe my gratitude to mentor in pediatric cataract surgery. While I worked with Dr. David Apple, I got opportunity to work with Dr. M.E. Wilson, who was pediatric surgeon, and I also achieved my inspiration for pediatric cataract from Dr. Abhay Vasavada. While we see these children with pediatric cataract, usually they come with visually significant cataract, and I think I have documentation of more than 12,000 children, their clinical photograph as well as wherever possible slit lamp photograph also. Each of the child which you operate, it is better to dilate the pupil, because dilatation will tell you that what is the type of cataract, whether it is a zonular cataract or whether it is a posterior lenticonus or it is a PHPV or persistent fetal vessel or any other problem of dilatation. So I think first is just a small simple video. In a more complex pediatric cataract, we have to diagnose, then plan what type of surgery, innovate, sometime execute, and I think extremely important is follow-up of these children. First, I think already Dr. Farooq Chawla Gupta as well as Dr. Jaspreet, they have already highlighted the steps of pediatric cataract surgery in a normal case. But this is a very small video clip that how you make main incision, side port incision, and stain the anterior lens capsule and perform continuous curvilinear capsular axis. Ideal size is approximately 5 mm or so. After hydrodissection, remove the cortex from the capsular bag. Remove each fiber of the cortex and then do primary posterior capsulotomy. Initial nick is with needle cystitome and followed by formation of the posterior axis by Utrata forceps. Usually there will be least vitreous disturbance, but any vitreous, little vitreous traction, I think you remove that. And place IOL, as Dr. Jaspreet said, in the capsular bag. It is always hydrophobic acrylic IOL, but we have used initially PMMA IOL or heparin surface coated IOL also. Then going to the complicated pediatric cataract cases, several cases you see PHPV, posterior lenticonus, ophthalmos, microphthalmos, JIA cases. So here it is a first case which is a 2-year-old child with pre-existing posterior capsular dehiscence. You can see the anterior segment OCT on the side. We anticipate that this child will have posterior capsular tear. So you have to do limited hydrodissection and remove the cortex from the capsular bag. So as anticipated, there was a posterior capsular tear, and IOL is implanted into capsular bag. And sometimes little traction may be there, vitreous traction, so that is removed. Best is detected by triamcinolone injection, and this is 8 months later, clear visual axis, and this is IOL position by anterior segment OCT. This is another child with juvenile idiopathic arthritis with uveitis. Synechotomy was done, and the Malaysian ring is injected to achieve good dilatation of the pupil. And now we achieved excellent dilatation, excellent size pupil, and then of course removal of the cortex and doing cataract surgery not difficult. This clip is, I think, more than 15-year-old. That time we only had this Malaysian ring. Now we have Bhattacharya ring and several other rings also. So here we did peripheral iodectomy because we expected that there will be occlusio pupilli. Then come another case with lenticular coloboma with high corneal astigmatism. So here it is not issue of implantation of the IOL. Here there is another issue that we have to achieve centration of the IOL. I think which is best achieved by fixation of the capsular bag. These are the capsular hook. And cortex is removed from the capsular bag. And Sioni ring is implanted into capsular bag, and to achieve the perfect centration of the IOL in the bag. So here we are using toric IOL, using Callisto, and this is after implantation of IOL in the bag, and then now we achieved excellent centration. This is to show the before surgery and after surgery implantation of the IOL. And then comes a double crystalline lens. I did this a very small clip having two lenticular two lenses in the same eye. Here I think this is the only case where I did two continuous curvilinear capsular axes on each of the lobe of the lens, and we designed a customized IOL. And this was a 18mm long IOL which was implanted into each of the capsular bag. Central area was aphakic. So amblyopia therapy was initiated for this child. And this child could achieve good vision. We have follow-up of more than 10 years for this child. child is myopic by 1.5 diopter. Then probably the last clip where it is a 1-year-old child with PHPV. It is a hemorrhagic type of PHPV. So these are this is again a complicated situation where we have to do cauterization of the vascularized posterior capsule and primary posterior capsulotomy. Usually vena seizure may help you because sometimes even cutter will not cut a thick membrane. Here it is just cutting of the stalk after cauterization and doing limited anterior vitrectomy. And here we can do optic capture again, optic in the capsular bag and haptic in the sulcus. So these are some of the other cases of PHPV. Classical PHPV, this is a very advanced PHPV where posterior capsule is totally vascularized. So this is where it is extremely important to achieve long-term follow-up. One child where IOL was implanted in 1997 and after 25 years in 2022 he completed his MBBS. It means his vision was excellent. His vision is 6/6 but he is myopic. Of course myopia is good for him. It is 1.5, 1.75 diopter myopia. So some I think that is not a very big thing. But I have a follow-up of 33 year, 35 year, up to 40 year follow-up of these children. And anyway, I am thankful to all of you for attending this instruction course, and I am thankful to my faculty, Dr. Love, Dr. Jaspreet Sukhija, and Dr. Parul Chawla Gupta, and all of you. Audience, I think now whatever limited time we have, we can discuss whatever are the remaining questions. We have almost 8 minutes or so.
Sir, which cautery was used for
What cautery was used?
what cautery was used for the PHPV case?
For PHPV.
The cautery, the instrument.
Cautery, I think it is a retinal cautery. Retinal cautery, anterior segment surgeon, we don't have much of the thing with us. So whatever retinal surgeon, Dr. Saab and these people, they have excellent retinal, they have excellent that micro vena seizure and cautery. They are used for that. We use their and I think cauterization is extremely important, whether it is a posterior capsular vascularized posterior capsular membrane or whether it is a stalk. Both of them that should be cauterized. Otherwise bleeding will be there. IOL power calculation. This was a topic by Dr. Love. And we do under correction. You know how we had evolution. Initially 1997 there was a Dahan's guideline. That time nothing much was known. Journal of Cataract and Refractive Surgery, there was guidelines that for children up to 2 years 20% correction, from 2 to 8 years 10% under correction. These were the guidelines, not a formula. So we used to do that initially. Then we did all the other formula, SRK2, SRKT, Barrett, and recently SRKT and Barrett. So and that also with the under correction and keeping a balance that how much under correction. It should not be a more under, it should not be just to keep +7, 6, 7 diopter of hypermetropia, that will, ruin the that will have a much imbalance. So that you have to adjust that part.
I think in young children who do not cooperate for optical biometry, this is all a rough estimate of the IOL because they are not fixating. So you have an A scan with which you are doing the axial length. So you are bound to get your errors. Yeah.
And Dr. Love, he intraoperatively that very nicely he showed how we do the keratometry. But that keratometry will also change. Initially, it may be say 48 to 50. It will come out to 44, 43, 44. So that estimate also you have to balance. So it is a bit complicated, but it is not 100% accuracy that whatever we do, but it should be reasonably accurate.
Further to our initial discussion on preventing posterior synechiae, I sometimes find using in children whom we leave a phakic, sometimes what happens is pupil becomes very small and later doing retinoscopy also becomes very difficult. So what I do is I usually follow a twice weekly atropine ointment. I ask the mother to apply atropine ointment twice a week, not daily, twice a week. So the pupil remains a little bigger and synechiae doesn't develop. At the same time, you don't. It's easy to do a retinoscopy also whenever the child comes to us. That I follow.
I think this is extremely important. If people is adhered, sometime it may be 360 degrees, but never use pilocarpine at the end of surgery. That is one. Second thing is that use dilator. We often use cyclopentolate, but sometimes we diluted cyclopentolate plus we use homide otherwise, but sometimes we dilate it with tropicamide, some diluted one, which retinal surgeon also use for dilatation of these children. So because we mobilize the people, that is very, very important. Otherwise, even retinoscopy is difficult for optometrist.
Regarding IOL power, the formula to be used, there was a study by Chang et al. In 2020. They said they used 8 formulae in children up till 8 years of age. And they said that in children less than 2 years of age, SRK-T was most accurate with the least prediction error. And from 2 to 8 years, it was Barrett's.
So this is the recent, whatever I said, evolution, that initially we used SRK2, then SRK-T, then this Barrett. So there was a change, whatever in our thought process also. No more question? We are grateful to all of you for attending our instruction course, and I am thankful to my faculty here. Thank you so much.
Have become in inertia now.
What is inertia?
It can't move from that place now. Synechiae has developed.
Okay.
Thank you.